Welcome back to the channel. I'm Dr. Trey Martin. I'm a doctor of physical therapy who primarily works with baseball athletes and helps them rehab, stay on the field, stay healthy, all that good stuff. For today's video, we're going to be talking about Thoracic Outlet Syndrome and specifically Venous Thoracic Outlet Syndrome. So when we look into thoracic outlet syndrome, we have three types. Neurogenic makes up 90% of the cases. We have arterial and we have venous. So it's basically naming what area is getting impacted from the thoracic outlet. If it's nerve, neurogenic, 90% of the cases again. Venous is probably in that 5 to 7% of the range, and then arterial makes up the rest. And sometimes you'll see a little combination of factors in a couple different things, but it gets chiefly named on the prime symptoms that we're seeing. So if we're seeing something more vascular, we're going to have vascular-based symptoms. If you have more of a venous occlusion, you can see that kind of like backflow issue, some swelling, discoloration, bruising type of thing. Arterial's a little bit more of that kind of blow-up-y, pulsy type feel. Then again, neurogenic's that kind of numbness where it's like you kind of feel like your hand doesn't work quite as well as it would. So if we start looking into the more of the vascular-based systems of things, again, they're fairly rare. I've not seen one clinically yet. I see neurogenic probably every couple months. I'll have a guy come in that has true neurogenic thoracic outlet syndrome. And we've seen multiple pictures of the major league levels that will go down with, they'll get their first rib removed or they'll get part of the clavicle resected here. So it's a super common condition that you see in baseball guys. I remember Matt Harvey being fairly well known a few years ago as top of the game, you know, just shoving in an all-star game. And then one day it's like, what happened to Matt Harvey? He got part of his rib removed. He couldn't feel the ball as well. So it's pretty common. One of my mentors actually once said that he believes that Major League Baseball players are on a spectrum of thoracic outlet syndrome where it's like they either have it to the point that they have clinical symptoms or it's not that noticeable, but they all have some varying degree of it. And why that is because as we throw, we're going to start developing a little bit extra muscle hypertrophy and thickening in both the scalenes and also in pec minor, pec major. And then you combine that in with some mobility restrictions we see in throwers where they start to kind of tighten down a little bit on the front side. And then we don't have enough space for the thoracic bundle to exit from the neck all the way down and to serve the hand with, you know, nerve and artery and, you know, blood flow essentially. So to keep it very simple, that's just our overview there. I don't want this to be a video where you're like, I need to go to med school to understand what's going on. I like to keep things simple, straight to the point. So thoracic outlet, simple, all intents and purposes, from the neck, comes all the way down into the hand, and then we have our outlet here as it crosses through into the shoulder. So common occlusion points we see, again, those scalenes, if you like that, you'll feel the scalenes pop up. So they attach into the first rib and they could cause symptoms of thoracic outlet syndrome. So that's going to be a prime cause in normal populations. Another area that we see, and I see this more frequently in baseball guys, is in that like pec minor area. We'll see that become a little bit thickened too. So pec minor is probably a little bit more prevalent in baseball people. Scalenes more in gen pop, but it can be a little bit of both. Symptomology that we're going to see, again, neurogenic, nervy. If we get into this vascular question, answer more of like the venous outflow problem, we're going to see this kind of backflow, bruising, discoloration, swelling. You can see blood clots form too, so this is a pretty serious condition that you need to get taken care of pretty quickly. So standard medical practice on something like this is they can put you on like blood thinners or things like that if you're starting to have some clotting. I'm not a doctor. Don't take that as medical advice at all. Well, I'm a doctor. My grandma calls me a doctor because I'm a DPT, but different, you know, I don't prescribe drugs. So go talk to your guy that prescribes drugs if you're having this. Okay, so now that we've touched a little bit on relevant anatomy, I want to talk about diagnosis. Thoracic outlet is a notoriously hard thing to diagnose. There's some clinical table testing where it's like they have you do this, the happy chicken, have you do some different testing like that, and I'll just go ahead and say it, like, I find that for diagnostics of thoracic outlet syndrome, the easiest way to get an accurate diagnosis is you need a doctor or someone that is familiar with thoracic outlet at least, nurse, PA, PT, chiro. You need someone that actually listens to your full story and they can go through the signs and symptoms. The subjective exam is by far the most telling thing that you're going to find on thoracic outlet syndrome. If I have a baseball guy that comes to me and says, hey man, like, you know, I was up to 90 miles an hour, I was feeling pretty good, and then one day I started to lose some touch on a pitch, or like, you know, maybe I was noticing some like, you know, bruising if it was more of a vascular based one, or like swelling, or I'm just not bouncing back, and normally they'll say something about the touch thing, where it's just like, it just doesn't feel like the ball feels as good as it did, or maybe they're starting to get a little yippy, they can't pick off to first, the catcher's not throwing it back to the pitcher well anymore. If I start hearing those kind of things, I start thinking, you know, it's more of that like subclinical level of thoracic outlet syndrome. And sometimes you'll get cases where it's just, you know, screaming obvious, where it's like this whole thing is like kind of tight and locked up, and you can just directly pinpoint the issue. But that being said, the table testing and some like the normal, it looks like a lot of things. And the thoracic outlet, for whatever reason, the medical world, the orthos want the shoulder, the neuros want the neck, and it just, you know, it gets in this weird no man's land where it's like the thoracic surgeons and the cardiac people, like, it's kind of a blend of things, you know, like it's kind of a neuro ortho cardiac thing. So sometimes it just kind of gets into no man's land where you get past doctor to doctor and no one really knows how to solve it. So it is important for you to kind of know relevant signs and symptoms, especially, and I'm speaking mainly to my baseball population here. If you start losing some feel in the hand and it's not really painful, but it just feels a little nervy and off, you got to start thinking that way. Like, look at the neck, look at the thoracic outlet, and definitely if you get any, like, you know, coldness, loss of feeling in the hands, clamminess, nervy, anything changing there, not good, get it checked out. Now, more advanced medical testing, MRI, ultrasound, you know, CT scans, EMGs, they can do some things like that that are a little bit more, well, out of my scope of practice, unfortunately, but a little bit more refined, that can give us some better insight on whether or not it is true thoracic outlet, but even that's kind of difficult. The ironic gold standard is Botox. I know, right? You think Botox keeps you looking young, anti-wrinkling, but turns out Botox, if you inject it into the middle or anterior scalene and it works, there's your diagnosis. You have actual thoracic outlet syndrome. And the nice thing about it is it can actually also be fairly curative in a lot of people. So it's a really cool, you know, you figure it out if you have thoracic outlet, and you also get a good treatment out of it. Otherwise, more the conservative route where I come in, we're wanting to create as much space as we can on the front side of the shoulder. So if you're very pec minor dominant, you're tilted forward, you're kind of stuck here in this spot, you're chronically tight there, PT-wise, we're gonna work on mobilizing the heck out of that and then strengthening the mess out of the backside of the shoulder. This is gonna, you know, full disclosure, I'm going to make my spiel here. My arm care app that I have, NPH Baseball app, addresses a lot of these things. It's not, I'm not saying it addresses thoracic outlet syndrome, but it is built primarily to free up this side of the shoulder, strengthen the back side of the shoulder to keep you healthy. But let's go through a couple just relevant pieces of exercises I would have with someone doing with, say, venous thoracic outlet syndrome. It depends on the severity, first of all. If you come in and it's just, you know, swollen, bruised, like can't really move it at all, and you just got prescribed, like, you know, warfarin or something like that, or Coumadin or a blood thinner, that kind of thing, we might have to start with very, very gentle range of motion. It might look like a lot of table time where it's like I'm just doing some soft tissue work through the pec, the lat, subscap, trying to free up these guys that drive internal rotation and that kind of tilt position of the scap. And then, you know, maybe we're going to start incorporating some light strengthening. From there, if you come in and it's kind of like a moderate case, or we've already gotten through to where this is a little bit desensitized, we're starting to get some flow and feel back again, then we're going to just be hammering scap work, eyes wise, T's, dumbbell ER, serratus work, rows, sled pulls, like that kind of thing. Like that's going to be kind of our general framework. I'll kind of hyperlink a few videos throughout this, so just we'll kind of PIP it so you can kind of see just some ideas of this. That's to be said, though, I would go find someone like me in your community or shoot me an email. Like, you need something more like prescriptive for you, because it really depends on staging and it depends on what your issue is. So if it's more, well, one thing, let me back up a second. One thing that it needs to be noted with this is you can't progress this too fast. If it's less is more with this one. It's more of like easing the tension, freeing it up, working on neck range of motion, thoracic range of motion, shoulder mobility first, and then trying to kind of figure out, like, in my throwing routine, are my volumes too high? What caused this spike that caused this to lock up for me? So once you solve that, then you can start layering on the strength part. If you start layering on strength too quickly, you jump back into throwing too quickly, it'll come right back. So that's kind of the conservative standpoint of things and how that looks. I would say most people try that route first, and then in cases that it's not really going that way, like, you know, that Botox injection is kind of that like intermediate tier, and then the third tier is like getting like either first rib resected or clavicle, you know, cut, basically, where they cut that out, move a scalene, reattach it just to create more space. That's kind of the worst case scenario. It's not preferred. That leads to some issues down the road too. So preferably the rehab Botox approach works. And I would say that that's fairly successful with thoracic outlet cases. I would say it's probably 60 to 70% of the time PT is enough to get them on the right track. But occasionally you have some people when they get back to throwing and this scalene hypertrophies again, pec tightens down again, hypertrophies again, then we'll see it kind of, you know, come back with time. So it really depends on your throwing volumes. But all in all, it's a very, very challenging condition. It's hard to diagnose. So you need to find someone that's a provider that has some experience with thoracic outlet, some experience with baseball. But yeah, we'll go ahead and wrap up with that. I hope you guys got a lot out of this. We went through some anatomy, signs, symptoms, diagnostics, and just a few ideas from a rehab standpoint. If you need any help, I know this is a very complicated issue, drop some comments or email me at trey@athletedocrehab.com, and I'll try to point the right direction best I can. Thanks for tuning in.